Hi, my name is Kunal Jain. I'm a head and neck cancer and microvascular surgeon and an assistant professor at the Department of Otorhinolaryngology, Head and Neck Surgery at McGovern Medical School, UT Physicians, affiliated with Memorial Hermann Texas Medical Center. So throat cancer is primarily cancer in the back of your tonsils or in the back of your tongue that we're seeing nowadays. And it's different from cancer of your tongue or in the front of your mouth. This is more in the back of your throat, which is when we kind of talk about throat cancer or oropharynx cancer. Those are the two main areas we're referring to, and also the back of your throat itself and the top of your palate. So the causes of throat cancer, they used to be traditionally, smoking and drinking, but what we've seen actually is the head and neck cancer and most of the other places in the head and neck have actually gone down in the last 30 or 40 years, except the throat cancer is going up. And so it really led us to ask the question as to why this is happening. And the answer was actually the same virus that was causing cervical cancer in women, which is the human papillomavirus or the HPV virus, is what's causing the throat cancer, and that's what we're seeing increase. Since the 1990s, this has been going up, and that actually is supposed to overtake cervical cancer in about 20 years. So there's a lot of things that we're doing to kind of prevent this in the future, which primarily one of them is vaccinating the children, but there's a whole generation that wasn't vaccinated, and that's why we're seeing this spike. And so one of the things we're working on right now is to treat this. Some of the symptoms that patients will come to us with is, this is a fairly innocuous, or there's not always a glaring sign, but the most common thing that they come in with is a mass in their neck, or they are having some problems swallowing, some changes in their voice, or ear pain, because sometimes even the pain from your throat is your brain confuses it as ear pain. So those are some of the signs and symptoms that patients present with. The other thing they may have is some weight loss as well, in addition to all these other things. So once the patient comes to my office with any of these symptoms, the initial thing we do is, full thorough head and neck exam, which also includes taking a look with the camera through your nose in the back of your throat. It's fairly painless. I've had it done to myself. It doesn't hurt. We start with that. If we can see where the cancer is coming from, or if we are suspicious that it's cancer, then usually we'll take the patient to the operating room for a biopsy of this area. If there is nothing that's obvious, then we'll potentially biopsy anything that's on the outside. So if they presented with a swelling in their neck, then we might biopsy that. In addition to all of these things, we usually also get some sort of imaging study, which either includes a CAT scan or an MRI. So those are the kind of things we start off with to figure out what we're dealing with. So once we've diagnosed the patient with throat cancer, our next step, as any patient would ask us, is so what do I do next? So there's multiple treatment options. One of them includes radiation therapy and chemotherapy simultaneously. The other option is surgery alone. And the third option is surgery with the addition of radiation or chemotherapy, depending on what the final pathology or stage of the cancer is. There's different patients kind of fit different molds in terms of what would be the best choice for them. One of the things as our goal is to help them make that decision, make the best informed decision, and usually that's in conjunction with our team of the medical oncologists and radiation oncologists. So we discuss this at our tumor board, so we have a consensus decision as to what we're going to do and then recommend to the patient. Ultimately, it's the patient's choice as to what they would like, but we do make a recommendation of what we would think is the best care. So as far as my role, so if they go down the route of radiation and chemotherapy, then it's monitoring them after they've completed that treatment to make sure that the cancer doesn't come back. Sometimes if it does come back, then they may need surgery. Some patients, when it's early enough in their stage of the throat cancer, are actually candidates for what's actually just started in 2009 at the University of Pennsylvania, where I did my fellowship was transoral robotic surgery. So what that does is we actually operate on these cancers and are able to either reduce the radiation dose, or in some patients not get radiation at all. And in most patients, we are actually able to avoid chemotherapy entirely. So these are some of the advantages of doing this surgery. It's minimally invasive. It's through your mouth. There's no cuts on your face, so it's not disfiguring as previous surgeries used to be. And it allows the patients after 3 days of being in the hospital to go home. And usually most patients, 98% of patients, are able to swallow and talk normally. So there's huge strides that we've made in terms of progress, in terms of operating on these patients and having a good quality of life, because most of these patients are in their early 50s, and so we want them to have the best quality of life. So at our practice, we provide personalized care in a multidisciplinary team. I talk to the medical oncologist and the radiation oncologist almost on a daily basis. We also have, the other aspects of our care, including the speech therapists, audiologists working with us, again, as a team. So when the patient comes to our practice, they really feel like all their care is being coordinated. Everyone's in contact with each other. They don't necessarily have to fill in the other doctors and what's going on. And they really feel at ease in terms of that their care is being taken as well as at the best standard of care available in the U.S. So when you come to our practice, this is what you can expect.